Thanks, Roxana. It looks like they're making progress, and so I'm going to take you on a little bit of a journey. Some people would say an odyssey. Everybody who is a little bit younger and now has access to doing procedures like TAVR thinks that this developed quickly and without any speed bumps, but I will tell you that it was a stormy course, was an interesting time, and some of the real pioneers are in this room. So I would not presume to even mention TAVR without mentioning Eberhard Grube's name, who was there from the very beginning. So I'm going to at least give you some of my perspectives. And I was asked to start from the beginning, to give you a status update, then to look into the future. We'll get through as much of this as we can. If the case gets interesting and we want to come back, we can certainly do that. I usually begin a lecture like this by paying tribute to my friend and colleague Alain Crebier in Rouen, France. And this is the first case that was done, April 16th, 2002. This is 15 minutes after the procedure. This was a dying man in cardiogenic shock who had 3 previous operations, a pneumonectomy, ischemic limb disease with no femoral access, an ejection fraction of 10% with an LV thrombus, and critical aortic stenosis with multiple BAVs that kept recurring, who presented again in shock. This was the first case. This case was done without transesophageal echo. It was done retrograde, and it was done without general anesthesia. So we talk about the minimalist approach. That was the first case. And by the way, just to make life more interesting, it was a complex bicuspid valve. So this was the first case, and this is immediately after the case. And I spoke to him that day, and the first thing he said was, okay, what now? And then we didn't really know what the next steps were. This was a proof of concept to be able to transplant a human aortic valve without opening the chest. And frankly, we felt it would be limited largely to the highest risk patients who had no other alternatives for aortic valve replacement. So let me give you some insights into how it began. I could go way back, but it's best probably to start with Henning Ruud Andersen, who's an interventional cardiologist and a tinkerer and a very interesting inventor from Denmark. And he came up with a concept of putting a jugular vein valve on what looked like, as you can see here, almost a spiral ring. And this was the Andersen stent valve that he implanted into pig hearts beginning in 1989. You can see him now working on his pigs. It was almost impossible for him to get this published. It was finally published in the European Heart Journal in 1992. This is what one looked like. He developed some intellectual property on being able to put stent valves in the heart, which obviously became very important afterwards. Alain Crebier, off the frustrations of balloon aortic valvuloplasty, began to think about combining a valve with a frame that looked like a stent, and these are some of his earliest sketches in 1990. The decade of the 90s was trying to find people to work with. And by the end of the decade, we were able to put a group together, including 2 very good engineers who were very prominent in the stent days, Stan Rowe and Stan Rabinovich. And Alain, of course, was involved. I became involved out of my friendship with both the engineers and Alain, and we formed this entity called Percutaneous Valve Technologies, which only existed for a period of approximately 5 years. We looked at every conceivable prototype of valve configuration, leaflet material. We looked at biologic. We looked at prosthetic materials, extensive hydrodynamic testing, and all of the test equipment and crimping tools were designed by this company, PVT. And then we entered what we call the sheep era, which was 100 sheep that were studied outside of Paris in Cerebral, which is a wonderful experimental facility, to see if we could actually implant these in animals. We did a lot of cadaver work, and this was work that we did with Renu Vermani at AFIP, trying to understand. And for me, this was the existential moment that we could actually expand a balloon metallic frame in heavily calcified aortic stenosis, and it would be retained. In fact, retained to such an extent that you could not physically remove it. And we did many of these tests. That's me in the corner with Stan Rabinovich. And that all led to the first case. And I'll tell you the history of this first case. This is an email that was sent to me on April 12th by Alain Crebier, where he's introducing the first candidate that I just mentioned to you. He called it a fascinating case, as I said, young, EF 10%. It would be a transeptal or antegrade approach, which is a very difficult approach to do for a variety of reasons. He was on pressors and basically in shock. Had a thrombus, a mobile thrombus in the LV. Of course, made some comments about how he would do the procedure and asked, what do you think? Well, it's easy 7,000 miles away to be confident, and I responded to him, and I told him he had my complete support. We talked about putting in a balloon pump, maybe from the upper extremity, how to snare the stiff wire, and we agreed that there would be a high likelihood of failure, but maybe it would work and save his life, because he literally had no other options. So this was the procedure. It's very difficult when you cross the septum and you have to externalize a long wire and then go antegrade across the aortic valve, and then again, to maintain the wire position is difficult. If you put any traction on the loop in the LV, then you lift the anterior leaflet, the patient gets immediate MR and goes into shock and arrests on the table. So this is Alain and his team with Helene Elchananov, who is next to him. And he finally, after about an hour, is able to manipulate the catheters in the correct position, and you see him looking at the screen. This is literally seconds before deploying the valve. I want you to watch their eyes. And that's the implantation of the first transcatheter aortic valve. Fortunately, they didn't have to do rapid V pacing because the patient went into ventricular fibrillation and cardiac standstill. So they were able to basically deploy it on a still heart. And then a few minutes later, after removing the balloon, suddenly there's some cardiac action. The gradient had virtually disappeared. And this is the first echo of an implanted transcatheter aortic valve. So it worked. So this gives you an understanding of how difficult it was. And it really took an expert operator who had a great deal of persistence and surrounded by a wonderful team in order to accomplish this. So this is a few days later when they're drinking champagne at the bedside. We actually published that first case in Circulation because we were really committed to making sure that we were careful in documenting everything that we did. And his conclusion was very humble. He said that non-surgical implantation of a prosthetic heart valve can be successfully achieved with immediate and midterm hemodynamic and clinical improvement. And that's all we could say at the time. That patient lived 7 or 8 months and died due to complications associated with ischemic lower extremity disease. But the valve performed quite well, and fortunately it did keep him alive for that period of time. There were many early skeptics who worried about strokes, aortic rupture, coronary occlusion, mitral valve injury, instability of the valve with embolization, paravalvular regurgitation, vascular complications, what the ultimate durability would be, and other technical challenges. And I have to tell you, all of these things, in fact, have happened. So it was appropriate to be concerned, but most people felt that this was a crazy project that will fail. Just doing one case doesn't mean very much. And there was not a lot of support, in fact, a tremendous amount of early criticism. So after this landmark first case by Alain Cribier, the next several years were spent replicating and refining the procedure in just these kinds of patients, extreme risk patients. We did multiple registries in Europe and then in the United States starting in 2005, and these were feasibility registries with very early prototype equipment that we would hand crimp onto balloons that we would take off the shelf. So we were just learning how to do this procedure in the early 2000s. Many people contributed to that process and should be recognized. This is John Webb with Alain Cribier, and John really contributed in many ways, but his major early contribution was really to innovate the transfemoral retrograde approach. He felt strongly this was the correct way to do it, and he developed many of the steps and did some of the early implants with Alain. We felt that we couldn't treat everybody with these very large profile devices using a retrograde arterial approach. So the transapical approach was developed in 2004. This is a picture in Leipzig with Michael Mack and Fred Moore, with Alain Cribier doing a deal with the devil. So we began to develop the transapical approach, and in the early studies, half of the cases we did were transapical because of the limitations of these very large profile devices. The OD of the catheters for the larger valves were 29 French, and many of these elderly patients could not support that size catheter from the iliofemoral system. So those were the early days, and so where do we stand today? Well, despite the early success of TAVR in extreme risk patients, no one could have predicted, I think, that the evolution of this therapy into a mainstream mode would have the kind of impact that it's had on cardiovascular medicine. And I would argue that the reason for TAVR or TAVI's success really are 5 things. There was very rapid and strategic technology evolution. The procedures kept being refined and simplified. There was an avalanche of clinical evidence that surrounded this technology and this technique, the acceptance of this multidisciplinary heart team, and all of which contributed to explosive growth worldwide. And all of this combined, I think, to account for the success. This gives you an idea of the TAVR systems that were rapidly developed over a short period of time in order to make the procedures safer, more effective, easier to perform, lower profile devices, eliminating concerns about paravalvular regurgitation in most patients. When you look at the STS ACC TVT registry, you can see, even though transapical was used initially, clearly the preferred procedure was transfemoral. And with the reduced profile devices, we were able to almost exclusively implant these transfemoral in our lab. It's 95, 98% are transfemoral procedures. Then, of course, this minimalist strategy was developed, which means different things to different people, but certainly this made the procedure much easier. It reduced length of stay in the hospital, and almost all cases now worldwide are candidates for some version of a minimalist procedural strategy. Right now, the median length of stay after TAVR at Columbia is only 1 to 2 days, and that strikingly facilitated the acceptance of this procedure. An extreme example of that is shown here at Sacré-Cœur Hospital. This is the first case I know of same-day TAVR. It was done by a colleague of mine, Philippe Généreux, who is one of our fellows. That's the patient with the clock at 5 p.m., the surgeon and the cardiologist next to him. It's a youngish man with Hodgkin's disease and mantle radiation who had TAVR done that morning and left the hospital later that day. I'm not advocating this should be the way we do it, but it gives you a sense as to how profoundly effective you can be in terms of reducing length of stay with this procedure. I wrote this article with David Capodanno, who I like very much, and we summarized a few years ago all of the studies that were being done in TAVR, and at that time, there were 24 randomized clinical trials either completed or ongoing. Since 2007 in the United States, more than 15,000 patients have been enrolled in FDA studies, including 10 randomized trials with multiple generations of 4 different TAVR systems. Remember, for surgical AVR, there had never been a randomized clinical trial. So the level of evidence was extreme, so we could support some of the contentions about using this device in various lesion subsets. This concept of a heart team really has become embedded in most of the US and OUS systems, where we have many different subspecialties participating to both diagnosing the patient, making a decision about what should be done, doing the procedure. And now we're really also including the patient and the patient's family. There is a new concept of patient preference and shared decision-making that we're incorporating in all of the communication with patients. So the heart team is a major component of the success. And this shows you what the growth has been. In this year, we expect about 70,000 TAVR procedures in the United States, increasing to about 165,000, or a 2.5-fold increase by 2025. And 48% of the AVRs done in the United States will be TAVR this year. Next year, more than half will be TAVR in the US. That will increase to about 76%. Probably that's conservative by 2025. So 3 in 4 AVRs at least will be TAVR in the coming decade. It shows you how quickly the growth has been sustained. US will be about 40% of the worldwide number. The clinical research was important to us. We began 10 years ago what's called the VARC initiative to set the stage for the partner trials, which arguably became some of the most successful sequence of clinical trials ever performed, certainly in cardiovascular medicine. So we published a whole variety of manuscripts to standardize the clinical endpoints and many of the other aspects of doing this procedure. We worked together to develop this partner concept where we had 4 surgeons and 4 interventionalists who functioned as an executive committee to begin planning and executing the randomized clinical trials. This is a slide showing you from the very beginning all of the partner trials that were done. We don't have time to go into detail, but I just want to impress that over 3 generations of devices, more than 9,000 patients were included in these clinical trials with a series of TAVR systems, many of which were randomized trials to help us understand strengths and weaknesses associated with this technology. We developed an independent publications office, and by the end of last month, we had reached our 100th accepted publication from the partner trials with an additional 120 abstracts that have been presented at international and national meetings. So the evidence, I think, has been monumental, and I think it's made a difference in terms of the acceptance of this technology. These trials were combined with the Medtronic core valve studies, and I think they really did apply the highest level of clinical trial rigor. Between these 2 devices, 8 randomized trials trying to validate the relative safety and efficacy of TAVR versus control. And in this case, control was either medical therapy in extreme risk patients or surgery in other patients. And this has been in de-escalating risk strata over a 10-year period. We generally look at 4 different categories: the so-called extreme risk, which are functionally inoperable, high risk, intermediate, and low risk. Traditionally, this was really an artifact of the FDA to try to categorize risk strata so that we would not move too quickly and develop proper evidence in the patients that might be most needy and were not good operative candidates. In more contemporary thinking, we talk about higher risk and lower risk, and we don't use this kind of risk categorization any longer. But a 5th category that we don't mention much about is what we used to call cohort C, or the futility patients. These are patients with a life expectancy of less than a year. These are patients where we can develop and have some risk predictive models to identify which patients might have early mortality or poor clinical outcomes. They have extreme comorbidities, often with STS scores above 15%, often dominated by frailty and dementia. These patients should not get TAVR. These patients really are the futile patients where we have to use good judgment and treat them either with a balloon or hospice therapy. But it's important for everybody to realize that every patient should not get a valve just because it can be done. In those early days, we began to understand more about the phenotype of frailty, and now people talk about it very glibly, but it becomes very clear that both frailty and dementia were key components of this futility category of patients that we feel are too sick, in fact, or too far gone to have TAVR. And now we, in a quantitative way, look at frailty, and it becomes an important metrics in deciding how we treat patients. The extreme risk patients that are inoperable are patients where there's more than a 50% likelihood of death or irreversible morbidity if they were to have an operation. The decision to treat these patients usually is made by surgeons as the gatekeepers due to a variety of clinical and anatomic exclusions where TAVR is literally the only option. This was the first study from the Partner 1B trial looking at this group of patients, 358 patients that were randomized, and you can see there was an absolute difference in all-cause mortality of 20% by a year, which meant you only had to treat 5 patients to save a life in this patient group. And this is the earliest stages of literally a prototype therapy. Life expectancy was increased from 11 months to 30 months in these elderly, very comorbid patients. We then moved on to the high-risk patients who have high STS scores, many comorbidities or complex anatomic factors. Again, the surgeons are very intimately involved in these decision-making. Unless negative anatomic factors for TAVR, I must say it's preferred in these patients versus surgery. This randomized trial versus surgery indicated, just looking at all-cause mortality, non-inferiority compared to surgery. And out to 5 years, you can see the valve performance was essentially the same as surgical valves, which to us was frankly a surprise. This is the first core valve high-risk study, which also showed non-inferiority compared to surgery out to 5 years, with superiority looking at the valve hemodynamics. So a transcatheter valve having better hemodynamics at the end of 5 years compared to a surgical predicate valve, which is not something that we expected. Most recently, we've moved on to the moderate risk or intermediate risk patients. These are generally patients that are still elderly. They're still around 80 years old. STS score is in the range of 3 to 8. These are surgical candidates, and the choice of TAVR versus surgery is based on an assessment of clinical and anatomic factors. And also, we begin to take into account issues relating to patient preference. This is the largest randomized trial that we've ever done. It's the Partner 2A study, over 2,000 patients, intermediate risk, comparing TAVR versus surgery, showing that TAVR was slightly better than surgery, although that difference was not statistically significant. But when we looked at those patients that were only treated transfemorally, which is about 3/4 of the patients, it actually was superior to surgery, looking at a combined endpoint of all-cause mortality and disabling stroke. When we look at the newer valve, which is the SAPIEN 3 in intermediate risk patients, this is work that was done by Sushil Kodali, and we compared it to the surgical arm of P2A. Surgery was still better from the standpoint of vascular complications and paravalvular regurgitation. But in all of these other ways, there was a benefit associated with TAVR: mortality, strokes, kidney injury, bleeding, new-onset AF, hemodynamics, quality of life early, and also things like length of stay and days alive out of hospital. These results were clearly replicated in the CERTAVI trial, again showing with the same endpoint of all-cause mortality and disabling stroke, non-inferiority, and demonstrating actually a reduction in the disabling stroke rate compared to surgery. So it's very powerful when you have two different devices studied so rigorously, which show very similar data in carefully conducted randomized trials. This resulted in guidelines which indicate that TAVR is a 1A indication for the extreme or prohibitive risk patients. It's a 1A indication as an alternative to surgery in high-risk patients. It really is a 1A indication for intermediate risk. This was done before CERTAVI, and now that's been reevaluated. And certainly the category that we have not discussed are the low-risk patients. These are the ESC guidelines showing the same thing. Now, low-risk patients are interesting because if you look at the STS database, they comprise almost 80% of the total number of patients that get surgical AVR. So for us, this is the holy grail. If TAVR can be equivalent to surgery in the routine surgical patient, then this becomes a very powerful tool that will be the default therapy in the majority of patients. As I said, they have low risk, which means STS scores of less than 3. The mean age is between 65 and 80. These are the usual surgical patients. Many of these patients have bicuspid valves, although in the clinical trials that we're doing, mostly the bicuspids have been excluded. There are now 4 major randomized trials that are ongoing, and you'll begin to see data in the spring of 2019. This will certainly involve what we call a shared decision-making process in deciding which of these patients will get either surgery or TAVR, depending upon the clinical trial results. There is one small randomized trial that was done many years ago with an early version of the core valve system that looked at all comers, but it's only about 280 patients, but the STS scores were around 3. As you can see here, the patients were a little bit younger. They were just under 80 years old. And out to 5 years, you can see that there was no difference in these lower risk patients with core valve versus surgery. And once again, with improved hemodynamics that were carefully evaluated out to 5 years. This is the Partner 3 trial that will be presented, we hope, at the ACC in the spring, which is 1,000 patients, low-risk patients randomized to surgery. And a similar study that's been finished enrolling and we hope will also be presented at ACC, the Medtronic Evolute R low-risk trial as well. So we'll start seeing patients who are lower risk. I borrowed this slide from Sushil Kadali, but it really explains the transition that we've seen. In the earlier days, we would look at the patients who would do poorly with surgery and say, can we do TAVR in these patients? In the future, if these trials are successful, I think the primary motivation will be to decide who does well with TAVR, and the ones that don't, then maybe we'll consider for surgery. So it's a complete change in what the conversation is. Along this journey, we studied some very interesting subgroups, and I'll just give you a little insight into some of those. You've heard a lot about bioprosthetic valve failure and valve-in-valve. John Webb has taken a lead in this. We've published many manuscripts. This is the one that I like most, which is 365 prospective patients where the results were really striking in terms of improvement and clinical benefit with aortic valve-in-valve. And we just reported on the 3-year durability of that experience. This is work done by Pam Douglas and 2,500 patients, 10,500 echoes, demonstrating the durability, at least over the course of 5 years. And you can see that between 1 month and 5 years, on average, there was only a 1 millimeter change in valve area. Very few of these patients presented with reintervention, and most of those were for paravalvular leak. And over the course of 5 years, an increase in valve gradient of 20 millimeters was only found in 0.5%, and any mean gradient of greater than 40, also in 0.5%. So very stable results in the first 5 years. Now we have new guidelines as to how to assess durability in bioprosthetic valve failure. And I think that those are going to be important as we look forward and decide how durable these systems are compared to the surgical predicate valves. Those definitions were applied in the patients in the NOTION trial, low-risk patients. And if you look at just hemodynamic structural valve deterioration, the transcatheter valve was much better than the surgical valve out to 6 or 7 years. When you add some clinical factors, it's about the same. So there's no evidence that there's any difference in terms of valve performance, but there's no question as well that we need much, much more data. Other factors that I think are interesting is the quality of life in these patients. This is work that David Cohn did, demonstrating on average in the earlier trials a 25-point improvement in KCCQ scores. Earlier with TAVR than surgery, but certainly these patients are transformed from a clinical standpoint. And most recently, this cost analysis is fascinating. This is looking at the SAPIEN 3 data compared to surgery, and the in-hospital and out-of-hospital costs in intermediate-risk patients were better with TAVR than surgery. And if you do a very traditional cost-effectiveness analysis, looking at incremental costs, it's unusual to see a therapy where there are clinical benefits and reduced costs. So this was described as a dominant therapy compared to surgery from a cost-effectiveness standpoint in intermediate-risk patients. So this has become a routine procedure with over 1,000 centers worldwide and almost 600 in the US for patients with severe symptomatic AS. The transfemoral approach is the default approach, and the minimalist strategy is favored. The heart valve team is the central vehicle for coordinating diagnostic and therapy decisions. Current primary TAVR technology is now stabilized, but there are new systems which are being evaluated in the US and elsewhere. At least in the US, the current standards are Evolut RN Pro and SAPIEN 3. The next in line are the Lotus Edge, Accurate Neo, and Portico. Other ones that are being looked at much more critically now are the Jena valve, Centera, and a valve in China called the Venus A valve. There's many accessory technology which I think can improve clinical outcomes. Most recently, the introduction of cerebral embolic protection devices, including several clinical trials, 3 randomized trials with this one device, the Claret Sentinel device, which is shown here, which is a double filter protecting 3 out of the 4 vessels supplying blood to the brain. We did many studies with this device. This is the pivotal FDA study demonstrating that material is captured in essentially all patients. And in 25% of patients, you can see at least 25 particles which are visible to the naked eye. In this study, a post-hoc analysis showed 72-hour stroke rates that were reduced by more than 60%. And in a meta-analysis, there were clear, consistent benefits from the standpoint of clinical endpoints. These are data from Europe, the Ulm experience, And these are 4 independent studies, again showing that the number needed to prevent an event was in the range of about 20 or 25 treatment exposures, indicating the clinical robustness of this in preventing brain injury. It's not used systematically at all centers, although at Columbia and many other centers, we use it in pretty much every case now. And I think in the future, it'll become the gold standard. So I'll spend just a moment talking about the future. The success of TAVR really has catalyzed a second wave of clinical studies in patients with bicuspid disease, concomitant diseases, asymptomatic AS, moderate AS and heart failure, and high-risk severe AR. Bicuspid disease is a big problem, even in the elderly. We're just beginning to understand how to best define it and categorize the anatomic subtypes that would be most suitable for TAVR. In this study that was done comparing it to tricuspid disease with new generation valves, there has been improvement this is about a 600 patient trial that was presented by Raj Makar, and most recently, a propensity match study presented at TCT in over 1,700 patients indicated very similar outcomes in bi and tricuspid disease from the standpoint of mortality, strokes, and even paravalvular leak. Now, these were carefully selected candidates, and a randomized trial is on the way. The WATCH TAVR study has begun, which is AS and atrial fibrillation, comparing Watchman plus TAVR versus Watchman alone. We've enrolled almost 300 patients in the early TAVR study, which is a landmark trial in severe asymptomatic aortic stenosis. And we have about 50 patients enrolled in the TAVR Unload trial, which is also an interesting study. We're beginning to get more and more experience with new valve types in high-risk AR, and this is the Jena valve, which clips the native leaflets. We've done 9 cases so far at Columbia. With their new transfemoral system, there's no question that we'll be able to treat most patients with severe AR who would be good candidates and who are not surgical candidates. There are many innovative TAVR-related technologies which are being explored. Tissue-engineered heart valves are the way of the future. We've seen many of these now being developed by very progressive sites, mainly outside the United States. This technology, endogenous tissue restoration, is going to be going into clinical use in the aortic position later next year. So these are non-biologic valves. Bay Labs is a fascinating company that allows you to be able to obtain an echo with very little experience in your local pharmacy, and will use artificial intelligence and deep learning to read the echo on site, so you'll leave the experience with an understanding of whether or not you have aortic valve disease. And there are new aortic valve remodeling technologies that either score the leaflets or use electrohydraulic lithotripsy. This is a shockwave-like catheter to try to change the leaflets in those patients that are not good candidates for TAVR. We'll be looking at different classification schemes of aortic stenosis. Philippe Généraux has done some of this work looking at extent of cardiac disease so that we intervene at an earlier phase. We're also collaborating with Elazar Edelman, not just looking at the valve, but looking at the complex of the ventricle, the valve, and vascular dynamics to try to make decisions about when would be an earlier opportunity for treatment. There are many gaps in our knowledge, and we're trying to address many of those gaps. There have been early data suggesting that there is a poor leaflet motion, possibly thrombus, in some of these valves. Both surgical and transcatheter valves. We have randomized trials that are ongoing and a whole variety of new studies to try to understand what the best treatment will be. There's no question that we'll confront restenosis, or I should say valve failure, late with these devices, and we're going to have to understand together how to best treat that. We're concerned about coronary artery access, so the whole issue of whether or not we'll have access to the coronaries in younger patients who clearly will need coronary procedures is one we're going to have to overcome. And we've just begun to understand what should be the customized patient-based pharmacotherapy to manage these patients with TAVR. Right now, that may have been maybe one of the greatest needs. So I think by most meaningful criteria, TAVR has been a breakthrough technology. This was the original manuscript that was written by Ross and Brownwald more than 50 years ago in Circulation, talking about the natural history of aortic stenosis. And at the 50-year anniversary, we had the pleasure of listening to Dr. Brownwald discussing that manuscript and characterizing TAVR and cardiac surgery as the two major therapies, at least in his lifetime, to manage these patients with aortic stenosis. And then back to the beginning. This is the first patient we treated at Columbia. He was 92. He was a radiologist at Columbia. Had critical AS, could not walk across the room. We were able to successfully perform a retrograde procedure, and within a month he was playing golf and had walked 18 holes of golf, to give you a sense as to what it means. So I would say in closing that it really is all about the patients, and I think it's very important for us to realize that this is a remarkable therapy for even our most interesting and complex patients. They are the point of care, and I think the TAVR has helped us to manage some of these more difficult patients and should be thought of as being part of the exciting armamentarium of how we manage patients with aortic valve disease. Thank you very much.